Let's look at this blood pressure for a moment to look at pulse pressure, blood pressure, pulse rate and volume. This is the blood pressure of 125 systolic over 85. Okay. So the pulse pressure is the difference between systolic and diastolic pressure. So in this case it's 40 millimeters mercury. Right. That's sort of in the normal range. 120, 80, 40 millimeters mercury. Okay. If you are dealing with a blood pressure in this range, where you see the pulse pressure here is 120 pulse pressure millimeters mercury, this tells you that there's quite a big difference, as you know, between systolic and diastolic. This patient will be hyperdynamic because the amplitude of the pulse is related to the difference between systolic and diastolic. So a patient with a weak pulse after having bled 2 liters will have that sort of blood pressure with a narrowed pulse pressure of 20 in this case, isn't it? So if you feel a patient if you feel the radial pulse, point A, you can sort of say to yourself, the blood pressure systolic is probably 90 or above. If it's below 90, it's unlikely that you're going to feel a radial pulse. That's a nice, crude, quick gauge. Alright? It's not a rule, just a gauge. Right. If the pulse is weak, you probably can say to yourself the pulse pressure is probably quite narrow. And then if the history is the patient is dehydrated, 3 days of diarrhea or bled or whatever trauma, then you can say the patient could be hypovolemic. He's lost blood or lost fluid, leading to this weak, thready pulse. Now, if you've lost blood or you've dehydrated and your systolic is like this, what do you think is going to happen to your pulse rate? It's going to go up. Pulse rate, because you want to maintain your blood pressure and your cardiac output. And that's why you learn in physiology that cardiac output equals stroke volume times heart rate. Heart rate. And cardiac output as a factor of systemic peripheral resistance equals blood pressure. Yeah. So if the stroke volume is in the floor because of the dehydration, blood loss, your pulse rate must go up to maintain a cardiac output. And if your systemic resistance is up because your sympathetic system is in overdrive to try and maintain, if you're frightened, flight, you've lost blood, you die, and whatever, that keeps your resistance up, so the less cardiac output maintains your blood pressure. That's why you can still feel the pulse. Right? So pulse pressure is the difference. Now, in a patient with aortic incompetence, for instance, what happens to them is their aortic valve, as you know, does not function. It's say fixed like that for whatever reason. It's incompetent. That means it doesn't close properly. It can open, but it can't close. So what happens is when you pump the blood, there's probably more blood that's fallen back into the ventricle. So the stroke volume is big. Okay? So when systole happens, you pump a lot of blood, volume overload, into the aorta. Hence you push up the pressure up to 180. But then in diastole, when the pressure of the ventricle relaxes, the pressure will drop, and normally when the ventricle pressure drops below the aortic pressure, the valve closes and you maintain your diastolic pressure. But now, because the valve can't close, this is one chamber. This drops right down to the ventricular pressure, which relaxes to 60, 40, 30, 20 sometimes. Low. Hence you have a massive pulse pressure. Does that make sense? So the difference between the two, that's why in an aortic incompetence you have huge hyperdynamic. Because the wider the pulse pressure, the more dynamic the pulse. Then the amplitude of the pulse wave will look like this, as opposed to a normal which is like this. And that's why you get a water hammer pulse there. Because if you would lift the arm up and the blood goes up, but because of extra gravity you're putting into the equation, the fall back, you take more blood back into the ventricle by lifting the arm up. So the next beat is more dynamic and stronger, hence you feel it in your water hammer pulse. Okay. Everyone happy with this? Pulse pressure, blood. So blood pressure is the sideways pressure in that artery that's either in systole and diastole. So if the pressure is 180, that's very high. It's systolic pressure. But the diastolic pressure, if that's, for instance, 110, that's the minimal pressure at all time in the artery. And that is a different concept, and it's dangerous than hyperdynamic circulation. So you can have low pressures with a wide pulse pressure and a hyperdynamic circulation, or you can have a blood pressure of 190 over 140 and not have any hyperdynamic. People with high blood pressure doesn't necessarily have hyperdynamic circulation. They can have laminar flow but massive pressure. This is dangerous because that's the default pressure at all time in your arterial system. It goes from there up to there and back. That's why the diastolic is the sort of the more important one of the two, but systolic hypertension, if your blood pressure 190 over 80, is also relevant and is also a risk factor for stroke. It's also an issue. Can't say, oh, the bottom one is fine, the diastolic. No. But this is a critical one. Does everyone understand that? Okay. So, let's quickly talk about the heart sounds quickly. So, this is the left ventricle, and there is the mitral valve. There's the AHJ. Now, what causes the sound or the intensity of the sound when the first heart sounds closed? Obviously, the same thing will happen on the right. So, say the blood level is there after diastole. If it's going to be less, is that heart sound going to be louder or softer?
Louder.
Yeah. So the less blood is in the ventricle, the louder the first sound because it smashes against that valve. As opposed to it being very full, and the cusp drifting on top and just pops closed in systole. So in atrial fibrillation, when there's varying lengths of diastole, you get varying volumes of end diastolic volume, getting varying intensity of S1, which is one of the signs of AF. Yeah. Now, in mitral stenosis, you can think about this mechanically. Will there be more or less blood in the ventricle in a mitral stenosis?
Less.
Must be less because it's stenotic, so the amount of blood that flows in here will be less. So, less blood. What is going to be the characteristic feature of the S1 sound in mitral stenosis? Loud S1. That's called you can get a tapping apex beat because of that forceful shut. Right, like a tapping second heart sound, which is a sign of pulmonary hypertension, a forceful shutting of the pulmonary valve. So that is why in a mitral stenosis you can get a loud S1. But in a mitral stenosis as well, thinking about it, that valve is diseased. It's not opening properly. Hence you get the stenosis. Okay, it's not opening properly. But because of that, it doesn't also drift easily on top of blood that comes in. So that's why it sort of shuts closed. That's why it creates that loud S1. But because it also is it can be quite stiff, it also opens quite forcefully. And that's why you can get an opening snap, which is a loud opening of this valve. So the classic mitral stenosis murmur is characterized by loud S1, opening snap with a diastolic rumble murmur, which is accentuated towards the end of diastole. So you call it pre-systolic accentuation of the murmur, because the atria contracts and then it forces a bit more blood through the valve, so there's a bit more extra turbulence. So that's why it goes loud. So it goes rrr, rrr, rrr. Whereas in atrial fibrillation, what will happen? Will you get pre-systolic accentuation of a mitral stenosis in AF? Tanita? I can't see your name, your hair is in the front. Tarika. Why would that not happen in AF? Can you see the mechanics? Does the atria contract in AF? They go like this. They just fibrillate. Fibrillate doesn't mean you can contract and force blood through a valve. They just vibrate. That's atrial fibrillation. Now, will you get, because you have no atrial contraction, you don't have pre-systolic accentuation of mitral stenosis. So you just hear r, r, not r, r. There's not that at the end accentuation. That's how you pick up AF, mitral stenosis, but no accentuation, confirms AF. Everyone happy with that? So the second sound has a splitting to it physiologically. When you take a deep breath, listen now, also I'm going to explain that other one. If you take a deep breath in the thorax normally has negative pressure in the pleural cavity. That keeps the lungs inflated. If you want more air in the lungs, you need to make the cavity more negative. You take a deep breath, push the diaphragm down, lift up the chest, you create a bigger space with the same amount of volume, so it drops the pressure. So what will happen? Your lungs wants to fill it, so you suck air in. You breathe indirectly, essentially. It's not air pushing in, it's air sucking in from the chest cavity movements. So that's negative pressure. What then happens is, if you take a deep breath and you make the pressure in the pleural cavity more negative, you increase the amount of pull on the blood back to the ventricle. Yes? Because remember, that's one of the ways the blood gets back is the negative pressure. If you make the pressure in the chest more negative, you'll increase the return of blood. So what happens with the JVP is, if it's going around here, if you take a deep breath and you drop the pressure in the thorax, you drop the JVP because the pressure in the right atrium will also go down quickly, just transiently. But if the JVP is high, which means the pressure in the right atrium is already increased, and now you take a deep breath, it can't drop because it's already overflowing, and now more blood will arrive, which means the pressure in the atrium will go up. That's Kushmal's sign. The book says you need to sit the patient forward at 90 degrees and take deep breaths in, or normal breaths in and out. I don't understand how that will bring out the sign. But maybe if the pressure is high already, the JVP will be so high that you will be able to see it if the patient sits at 90 degrees, and when he breathes in, it goes up and down and up and down. Okay. So, taking a deep breath decreases the pressure in the thorax, we will increase your venous return. But on the left side of the heart and in the pulmonary veins, you will pool the blood temporarily. Which means that when you take a deep breath for that split second or that second, you have less return to the left atrium, which will then register as not enough blood pumping, so your heart rate speeds up. That's when you get the sinus arrhythmia. When you take a deep breath, quicker heart rate, sympathetic outflow, and out. So it's a bit of a different system in the first second on the right versus the left. Does that make sense? Okay. So why does the second sound split? Well, it's easy. If you take a deep breath, you pull more blood into the left atrium and ventricle, so it takes longer to empty its load. So the valve will close just a bit later than the aortic valve. So that's why you then hear it's very close. And if he exhales, you reverse the process. The blood is sort of similar on both sides. You just hear lip, dip, lip, dip. It goes away. So that's a physiological splitting. It's moving during inspiration and expiration. That's normal. If it's fixed split, what happens there is for some other reason there's more blood on the right hand side than it's supposed to be, like in an atrial septal defect where the foramen ovale is open. So that means the atria functions as one chamber, and the amount of blood that flows over the tricuspid valve into the right ventricle is more than normal. So it will take more time to empty than normal consistently, hence the constant splitting.
So basically, with inspiration, that's why you also hear the murmurs on the right side more, because more blood's going.
More blood, more flow.
And with the left, it's either the same or softer, because less.
Yeah. We don't use it really for the left-hand side. So when you get to the dynamic maneuvers that's described in Talley and O'Connor, that's when you're trying to accentuate certain murmurs by doing something dynamic, like take a deep breath, doing a Valsalva, okay? Gripping fingers, which you increase your systemic resistance, or squatting and doing it. You increase your systemic resistance quickly by cutting off your femoral, not cutting off, but kinking the femoral artery a little bit and rising the pressure, so then the left-sided murmurs are louder. You can read about it in tele. They are not standard. We don't do it standard. We do it when we hear a murmur, we're trying to play with the murmur essentially. The standard ones we do is left lateral position for mitral stenosis accentuation and sitting forward for an aortic incompetence, because those are the most commonest two diastolic murmurs that are on the left. So I always say to you, left-sided murmurs, aortic and mitral are the commonest, then it's tricuspid, and then a distant fourth is pulmonary issues in terms of murmurs, stenosis or incompetence of the pulmonary valve. So we're trying to accentuate always the two diastolic murmurs on the left. Okay. Yes?
Just to backtrack a little bit, with your splitting, the fixed splitting, will it also change with deep inspiration?
It will move a little bit.
So how do you know when it's pathological?
Because if he exhales, it's still there.
Because they said that with some normal people have that.
Yes, but they have it. They can get rid of it with the exhale. Yeah. So normal people will have a physiological split, which moves. They say that it moves, whereas pathological is fixed. You can't get rid of it. Okay. So that's the split sound. The third and the fourth sound, this is important. If you have, in terms of the third sound, a ventricle that is baggy, so when there's heart failure, you get a ventricular sound in the middle of diastole, which is the third heart sound. So if I can show you, so here's the, let's draw it quickly. There's the sound, and there's the sound. So that's S1, and that's S2, and here would be systolic murmurs in between, isn't it? So diastole is here. Okay, here's diastole. Now, if you have a third heart sound, it is produced by the ventricle when the blood hits this baggy ventricle. Alright? And it's sort of sitting in the middle of diastole over here. And it's easier to pick it up, not by trying to listen, is there a third sound, but trying to just listen to the rhythm of the heart, because it produces a gallop. If you're in heart failure, your heart rate is normally higher because your stroke volume is down because you can't pump properly. But if you add a third heart sound, it sounds like you're getting a gallop of horses. When you hear the gallop, you see the horses running, as opposed to dip, 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 dip. Now you have Kentucky, 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 Kentucky. That's what Tally says. Kentucky is the sound it makes. So you listen in general to the murmur, to the rhythm. A fourth sound is an atrial sound produced when the atria contracts against a thickened left ventricle. So that's a sign of LVH. Okay? And it sits just before the first heart sound over there. That's where an S4 is, and here is where an S3 is. So this one you get, it sounds like a split first sound. Okay? And the way Tally says it's like Tennessee, 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 Tennessee. Okay? Tennessee, Tennessee, Tennessee. Alright? So that's a fourth sound. It's an atrial sound. This is a ventricular sound. Both are in diastole. Now, if the patient is in severe failure and the heart rate goes up and up, these two will come closer and closer. Then they can sit on top of each other and you don't know what's going on. Then you have a summated gallop, sort of a very loud gallop. You can read about it in Tally, and the pages are highlighted to you. Any questions about third and fourth sounds? So when you no, this is important. When you present your auscultation findings to a consultant or a registrar, you should comment on S1, loud, soft, red, normal. S2, loud, soft, normal. Any additional sounds, that's 3 and 4, or clicks or whatever, and murmurs. So those are the 4 things you need to comment on. S1, S2, additional sounds and murmurs. And about a murmur, so let me write it down. S1, S2, additional sounds and murmurs. Okay, now the murmurs also have 4 components you need to talk about. And they are listed in Tally. The first one is timing. Is it systolic or diastolic? We're obviously talking about a mono one problem valve issue or a murmur. What is the timing? Systolic, diastolic, and we spoke about that in semester 4 on the pulse, in between the pulse. The next one is maximum intensity area. Where is it based on the apex? That's called apical murmurs. Or is it left parasternal or around the aortic area? Where is it heard maximally loud? Where is it the loudest? Then we also talk about where does it radiate? Into the neck, into the axilla. What does it do? And the fourth one is the gradient. That's the grading, not the gradient, the grading. How loud is it? And remember we talk about Levine's grading of 1, 2, 3, 4, 5 or 6. The first 3 is no thrill. Is he okay? Okay. No thrill. Okay? The turbulence produced by these murmurs, their intensity cannot produce a palpable murmur. You can't feel the vibration. Whereas the bottom 3 is with a thrill. That's thrill, by the way. It's Hebrew. Okay, so and remember, to produce murmurs that can become this loud, you need a pump behind them. So the systolic ones can get up to a 5 and a 6 in terms of intensity. You know, the grading. So they all have thrills. So all you need to decide is when you do your examination and palpation, is there a thrill? No. So the maximum grade you can give the murmur is a 3. Yeah? That's easy. So you need, for systolic murmurs, they can get up to 5 and 6. Diastolic murmurs, because they're in passive inflow, there's no pump behind them, they just flow in a relaxed heart, they struggle to get above a 4. That's sort of the max intensity that it can get. So that's why sometimes diastolic murmurs are referred to as a 2 out of 4, or a 3 out of 4, or 4 out of 4. It's the same grading system of Levine, it's just because of diastolic murmurs can't get that high. They can't get this intense. We talk about it sometimes out of 4, but it's the same system. So a 2 out of 4 and a 2 out of 6, same intensity. Okay, so that's the grading. Now let's look at this. The pulsatile liver is in which valve lesion? Now you can't just say tricuspid. You need to say tricuspid and the lesion. Tricuspid valve, incompetence. Because if this is the right ventricle, the pulse wave generated by the contracting ventricle will go through the incompetent valve and spread up the superior vena cava and down the inferior vena cava. The SVC strikes up here the JVP, and you get a large V wave, and it hits the south, it hits the liver, causes liver expansion and congestion and expansion, and then it pulsatile as the wave hits it all the time from the ventricle. This brings me nicely to those 3 different concepts of the giant wave, the cannon wave, and the large V wave, as we spoke about in a JVP. And it's all got to do with the tricuspid valve. Now, is a cannon bigger than a giant?
It's a big cannon.
It's a big cannon. It's one of those cannons on the ships in the Middle Ages. Versus your average giant. Okay. And then a large V wave. So these are the A waves. If you look at that picture, the JVP, cannon A waves and giant A waves is to do with the atrial contraction. So if the atria contracts against a closed tricuspid valve, the only way that can happen is when the ventricle is also contracting and closing the valve. Or you don't have the valve. That's called tricuspid atresia. That's diagnosed in an infant on day 1, because when he becomes blue, okay, and it's life-threatening. Okay, so when you see an adult, you know it's highly unlikely to be tricuspid atresia. They don't make it to adulthood without surgery. Alright? So the only way you can get a closed tricuspid valve is a contracting ventricle. The only way that the atrium and the ventricle contract together, so that you can have a contracting atrium against a closed tricuspid valve, is when the atrium and the ventricle is not in synchronization. 3rd degree heart block, or 3rd degree AV block. Complete heart block. They're running separate systems. Okay, that gives you the cannon. Massive airways. The next step down is when you get contracting atria against a stenosed, closed, not shut, but stenosed tricuspid valve. So not all the blood can come back, some will go up again and give you large or giant A waves. And then the large V wave is when you have an incompetent one. The ventricle, it's a V wave. The ventricle gives you a large wave in the JVP and a pulsating nerve. So this is, when I say no tricuspid, that means closed. This is a small tricuspid, and this is a not working tricuspid. I don't know how to draw it now, but you need to get it. What a good idea. Okay, happy? Okay. Aortic stenosis pulse, that's an important one. Now, just look at this for a second. This is time, and this is the amplitude of a pulse. A normal pulse will go like this. Up and down, feel the pulse. Right, and then the next one here. Now, if you have aortic incompetence, what will the pulse wave look like? Is it going to be a smally one or a large one? But aortic incompetence, what does that give you? Darika, what does an aortic incompetence give you in terms of pulse? A high pulse. What's that mean? What's the word? You're on the right track, just word it like a doctor. Huh? Yeah. Don't fall down. Go. Hyperdynamic pulse. And how does that pulse wave, do you think, look? Like a small one or a... Yeah, so aortic incompetence looks like this. Massive amplitude. Because the pulse pressure is so wide, isn't it? This is pulse pressure. There's the normal 40, this is the 80. It should probably be there. Do you understand? Now, aortic stenosis. How will that one's pulse wave look? Is it going to be large or small? Yeah, because it's got you're fixing sort of the cardiac output. Huh? And how long will it take for the pulse wave? If you put your mouth full of water and I say spit it out with a nice open valve, as opposed to whistle it out. How long will it take for you to empty? Long or short? Long. Yeah. So that's why you take long to empty and come down. So it's just no. Sorry. Small wave but flat. That's very exaggerated. It's called a plateau pulse. A slow rising pulse of an aortic stenosis. A severe aortic stenosis. Okay? Plateau pulse. How does it feel? Touch, down. So it's not, it goes up and down. So there's a time delay before it goes down. Okay. Co-optation and blood pressure we spoke about. Pulse we spoke. JVP, everyone happy? Giant waves, Karen, happy? Level of edema. Just to mention, when you do the examination of the patient's edema for pitting, it's also important to look at how high does the edema stretch up in the patient. Is it only ankle, lower limb, thigh, scrotum, abdomen? How high does the edema go? That quantifies also the severity of the heart failure of the patient. And remember, if he's been bedridden for a while, the edema will not be in the legs, it will be sacrum, so you need to check that. Dynamic maneuvers we spoke about, and the negative pressure in the thorax. Happy about that. Is there any other question that any of you have? Yes?
I just saw that tally page 95.
Yeah, Tally, that's actually very good. On page 95 of the 6th edition of Tally, there's a lovely table. The way to approach that table is sort of your revision summary, where you can, it highlights all the issues of the important heart valve murmurs. And you can work out why it happens and where it radiates and the intensity and things like that. So that's a lovely summary table. Remember, you also get murmurs from non-valve lesions, like a VSD, ventricular septal defect, which is not a valve issue, but it gives you a beautiful murmur with a wonderful thrill song most of the time. Okay, so having a thrill or a murmur doesn't mean it's necessarily a valve. It's most of the time a valve. But you can have holes in the heart which can give you murmurs. Alright, that's page 95 telling you. Carotid, I can't remember what was that. We just have to listen over the carotid for bruits. Happy? Okay guys.